Welcome everyone to today's webinar, Too Big to Fail, Understanding and Reporting 340B Savings. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Andrew Wilson serves as McKesson's Vice President for 340B Solutions and Services. Andrew is responsible for overseeing McKesson Pharmaceutical Services and Solutions 340B strategy and 340B products. His prior work experience includes supply chain, pharmacy management, and operations consulting for Ernst & Young. He is a former hospital pharmacy director in academic health centers and integrated health systems, including the National Institutes of Health in Bethesda, Maryland. He has extensive 340B experience and serves as a faculty member of Apexis 340B University. Kevin Sheckelhoff serves as the Assistant Vice President for 340B Solutions and Services. Kevin leads the 340B Business Performance Solutions program, providing support for clients seeking to build specialty, retail, and other patient care businesses, including business planning and optimization of 340B programs. Kevin leads the team supporting McKesson's 340B Business Performance Dashboard. Kevin has 20 years of experience in acute care, long-term care, home health care, physician practice management, and supply chain consulting. Kevin's consulting focus is pharmacy service financial forecasting and analytics with an emphasis on the 340B program. He speaks frequently on 340B related topics and healthcare market reforms and serves as a faculty member of Apexis 340B University. At this time, I am pleased to turn the floor over to Andrew to begin today's presentation.
Thank you very much, Ayla, and thank you all for taking the time out of your busy schedule to attend. We recognize, and we'll spend some time chatting as well. COVID-19 has dramatically impacted those of us who work in hospitals, the time and attention that we're paying to the work that we do on a daily basis to make sure that we're prepared for the currently coming healthcare emergency. With that in mind, we will get to our major topic and do have an opportunity perhaps to chat a little bit about how 340B and 340B hospitals are impacted uniquely during this time. But I'll start out by making a quick note related to McKesson's commitment to do that. We're all McKesson folk on this end. The slide you see here is our Chief Operating Officer and the gentleman, Gene Cavacini, and the gentleman who runs our health systems business, Scott Miller. Myself and Kevin would all like to reiterate our continuing commitment not only to support you during the crisis, but throughout our work in the supply chain. We're one of the largest healthcare companies in the world, and we play a critical role. Kevin, myself, and others have been on daily calls to make certain that we continue to execute effectively during this time. If you are interested and do have questions or would like to know how we are responding or how you can take advantage of the programs or connect to the programs that we're running specifically to make certain that we retain our supply chain integrity during this time, you'll see there's a link on the bottom, mckesson.com/COVID-19, and I will direct you there. Also, would like to spend some time talking about what HRSA is doing here. There's not a lot coming from HRSA, and many of you are aware. HRSA has always had the option during the times of declared emergency to be flexible within the context of 340B and has done so. If you look on the website over the years, you've seen that during earthquakes, during hurricanes and other times, HRSA has undertaken to make it easier to register new sites or to engage in other activities with a unique way of looking at them in the light of the emergency. HRSA has issued the statement that's on this slide that they understand that everyone is concerned, but rather than having anything posted on the website to date, they're asking that you call Apexis answers and asks specific questions related to the changes or challenges that you're undergoing with 340B. So the eligibility page just show what HRSA has for opportunities to make changes, and I send you there. But if, as with many of us, you're looking at how to make sure that you continue to remain 340B compliant and yet work through a challenging supply chain, recommend that you call HRSA. And certainly, as a part of our commitment as McKesson, we'll work with you as well. Our agenda for today, which we'll go through fairly briskly in order to give you time for questions, is to talk about the 340B basics briefly. A number of you who are on the call are 340B veterans, but we also have some folks from finance and supply chain and other parts of your organizations that are not. So we'll spend about 5 minutes making sure that we go through the basics. We'll look at the size, the scope, and the reach of the 340B program. Talk about public dialogue related to 340B, and then dig a little bit into the statistics that are behind why 340B is so important. And I think we'll take two perspectives here, the first being what's going on at large in the marketplace, and the second being the local or hospital-focused approach. And then finally, we'll spend some time talking about 340B savings reporting and optimization. And Kevin will finish up by showing you a 340B dashboard, or talking about using a dashboard to track your 340B business performance. .340B basics. I'm going to start. The team that I lead at McKesson has spent approximately 10 years working in the trenches in 340B and has worked with many of you. We took the opportunity a year or so ago to work with ASHP to put together a book that outlines our thoughts and progress. We worked with others, including Apexis, to make sure that we had a reference that provided organizations with the opportunity to understand and to work with 340B effectively. But for the purposes of our webinar today, I'm going to outline the basics of 340B as really what I call in the first chapter 340B as a GPO, or a group purchasing organization. 340B really does look like a very special version of a hospital GPO. It looks like Premier or Vizient. Many of you are involved in the GPO work with other parts of your organization. But it's a unique GPO, and it has both a unique set of members as well as unique opportunities. It's run by the government instead of by a not-for-profit organization, and it has a statutory formula that drives deep discounts. It also has the ability to protect its members from price increases, and that's been a particularly great opportunity over the past 10 or 15 years, as price increases have been one of the factors in price and drug cost growth. It has a payer mix threshold for joining. If you're a disproportionate share hospital, you have to meet a DISH percentage in order to join. And it has, like many government programs, a unique set of granular management rules for purchasing and inventory management, including the unique requirement that discounted drugs can only be used in the treatment of specifically qualified patients. The covered outpatient drug and the 340B eligible patient definitions are unique and uniquely challenging for 340B entities. So I'll breeze through this pretty quickly, and for those of you who are not 340B veterans, the slides will give you this opportunity as well. But hospital 340B covered entity requirements are government older controlled, nonprofit if you're a non-government hospital. There's a threshold that we just talked about, and you need to apply. And then there are two really large scale of rules that drive the supply chain elements of 340B. First, you can't double dip with Medicaid. You have to carve out, or certainly have to work to make sure that there is no duplicate discount. And in keeping your inventory segregated or managed, DISH hospitals and others in the program cannot use GPO purchase of drugs for outpatients. There's a GPO prohibition. So at the end of the day, you need to maintain this separate virtual or physical inventory in order to make sure that you're running the program properly. Covered entities access 340B through their distributor or wholesaler. McKesson has a set of contracts and accounts that we put together. They're unique for the categories. In the case of hospitals, DISH, pediatric, and cancer hospitals have account setups, DISH, 340B, 340B, WAC, and GPO that recognize the GPO prohibition. And for the rural ACA hospitals, critical access, and rural referral centers, they have the orphan drug exclusion, and so we actually also maintain a separate contract portfolio for those as well. But within those contract portfolios and account setups, hospitals use a split billing for their purchasing. You prepare your order for the day. You look and see where you've used that drug previously or where that drug had been dispensed, inpatient or outpatient. And then your MacroHelix or other split billing software splits the purchase to make sure that you purchase no more than what you've used on 340B and GPO accordingly, with the remainder split to WAC if you're subject to the GPO prohibition. For contract pharmacy, that comes from your claims data and actually is a shared piece of information with your contract pharmacy partner. But again, software drives the purchasing decisions that you make. Briefly, the GPO prohibition, which is one of, I think, the larger challenges for our big hospitals, is that children's hospitals and freestanding cancer hospitals cannot obtain their covered outpatient drugs through the GPO. And so they require 3 accounts and require purchasing of significant chunks of their drugs at full list price in order to avoid that GPO prohibition. Kevin will talk about this a little bit later on as we talk about business performance in a dashboard. But we'll advise you to focus on WAC premium rather than WAC spend, and we'll spend some time actually going into that in some detail. Mostly for reference, and I think there's a couple of really good examples we'll bring up along the way. 340B pricing is a statutory formula, as I mentioned earlier. The 340B price can't exceed the AMP, which is a calculated average market price, minus a rebate percentage, which is set by the statute. At a minimum, it's AMP less 23.1% for brand name drugs and specialty drugs. And for generic drugs, it's AMP less 15%. The actual calculated prices are not publicly available, but participants in the 340B program can look at them through the OPIS, or the Office of Pharmacy Affairs Information System. 340B discount is typically about 25% below typical GPO pricing and about 50% off the average wholesale price. But best price provisions make some of the prices dramatically lower. An example I'll give you here is Rituxan. It's one that's rolled around much lower than that 23 or even deeper discount over the course of a number of years. And any drug manufacturer that participates in the Medicaid program is required to offer a 340B price. There are some inpatient prices available, but that is not particularly common. 340B program participation has grown pretty dramatically. We've got a couple of folks listed over here, and I will commend to you all of the information about 340B. 340B, I think, for a variety of reasons, has a fairly active conversation that goes on between opponents, or perhaps those who are critical of 340B might be a better way to describe them, and those that are active supporters. You'll see that on the right-hand side of the slide, I've actually put one of the larger critics here, Adam Fine, and Drug Channel, actually routinely questions the ways in which 340B is utilized by hospitals. But I will commend to you, and I'll make the point throughout, that 340B has grown large enough so that folks like the Berkeley Research Group, like Adam Fine, like others, including articles in Health Affairs, has come to look at this as a real factor in both hospital delivery of care as well as the pharmaceutical marketplace at large. I'd recommend to you, those of you who think of it from a policy perspective, to spend time looking at anybody who takes the time and effort to look at the size and scope of the 340B program. It's big enough to matter now, not just to the folks who participate, but to the folks who are participating in the rest of the supply chain in the drug policy world. So there are almost 14,000 or 13,000 covered entities now, 34,000 child sites, and almost 50,000 registered sites. 33,000 unique contract pharmacy locations. Almost half of all U.S. pharmacies are involved in 340B as contract pharmacies. But of the relatively large number, only about 2,300 340B hospitals, or 340B participants or hospitals, But now that represents over half of the voluntary not-for-profit hospitals. So this is a milestone that those of us who have been working in 340B for a while have anticipated for quite some time. More than half of non-for-profit hospitals now participate in 340B. Of those, 973 are disproportionate share hospitals, and the remaining 1362 are rural hospitals. But the lion's share of purchases are made by those 973 DSH hospitals. 340B sales in 2018, which is the last full year that this has all been kind of put together, were about $24 billion, about between 7 and 8% of U.S. drug sales. And interestingly, and growth here has a number of underpinnings. It has been 28% year over year for the past 4 years, and is likely to be the same in 2019 as well. The growth and use of specialty pharmaceuticals and the specialty pharmacy growth in the hospital segment continue to drive a significant portion of this. 340B savings was also calculated in 2018 and is a measure of how two organizations can look at this and come to a fairly similar answer. 340B Health surveyed its members and came up with a $11.8 million per facility savings over the roughly 1,300 hospitals that they surveyed. It comes up to about $15.3 billion in savings, represented by that $24 billion worth of spend. Drug channels, our friend Dr. Fine used a slightly different approach and came up with roughly $15 billion as well. I think the good news is that there appears to be some consensus. The challenging news is that granular assessments that are done for 340B are a little bit tougher to do because the drug prices themselves are actually remain confidential. Again, 80% of both the 340B sales and the savings is in hospitals, and the vast majority of that in DSH hospitals. One of the points I want to make, or one of the things that I want to make following off that slide, is that 340B is now woven into the fabric of not-for-profit hospitals everywhere. In 1992, when this program started, or certainly in the late 90s and early 2000s as the program grew, 340B hospitals were a relatively small subset of hospitals, and it had some unique elements which made them, as participants, different from the hospital group at large. What's happened over the past 20 years or so has been that 340B has become integrally woven into the hospital supply chain. And if you look, this is the example that I came up with in preparing for the webinar. The world's best hospitals list was put up by Newsweek just a couple of weeks ago. And if you look at the list, and I've actually listed the top 20 here, but if you look at the list that Newsweek put together of the consensus top hospitals in the United States, over 75% of the 100 best hospitals in the United States in 2020 participate in the 340B program. If I take that all the way out to 300, roughly 60% of the top 300 hospitals in the United States participate in the 340B program. Part of the too big to fail conversation that we're having today results from the fact the supply chain for hospitals to purchase drugs now has 340B woven throughout. A graphical view, back to the data that we just talked about, but 340B program growth and discount has been fairly dramatic over the years. You look as far back as 2012, really the 7-year period that I've got here, we've gone from 7 million to 24 million in sales, and from 10.6 billion to almost 40 billion if those sales were to be made at not 340B price. The difference between the dark blue bar and the light blue bar is the savings that's generated each year. 340B market size is significant, not just only in the context of the entirety of what is purchased for pharmaceuticals in the United States, but within the context of what's purchased by a hospital in the United States. It is a unique market. Rebates and discounts have changed as well too. So if we get back to that roughly 15 billion that we talked about, in the year of 2019, and these, I apologize, there are some, I'm flipping back and forth between 2018 and 2019 here for some of the statistics, so my math won't necessarily tie out quite so cleanly as one might like because I've selected it from a variety of sources. But in the year 2019, it's reasonable to calculate, and this comes from the Drug Channels Institute, Adam Fine, $175 billion worth of that gross to net bubble. So after everybody paid the list price for pharmaceuticals, the rebates and price concessions that were made to everyone from 340B hospitals to commercial payers, Medicare, Medicaid, everyone else along the way totaled $175 billion. Of that $175 billion, 10% of it actually went back to hospitals in the form of 340B discounts. So hospitals took roughly 10%, or 340B hospitals took roughly 10% of the total $175 billion that was rebated back. You'll see also here that commercial payers took 26, 23 to Medicare Part D, and 18 to Medicaid. But again, the moral or the backstory here is that 340B is measurable at all. 10 years ago, 340B was not a measurable part of this gross to net bubble, and as the gross to net bubble has grown, 340B has grown as well and has become a significant part of it as well. So as manufacturers and policymakers look to take that $175 billion and figure out how it's being given back to providers and patients, know that 340B, one of the risks to the 340B program is that some of that $175 billion is what's going into the hospital systems as well. Price change impact in particular has been significant as well. Again, we look back to, that graph I showed you that went from 2013 to 2018. This is from the Berkeley Research Group, looked at what had happened to 340B discounts, or what had happened to the retained margin for 340B over the course of that roughly 7-year period. It's grown about 9-fold. So the good news for all of us has been that 340B hospitals have enjoyed the continued growth of savings over time. Price change has driven that, as well as the growth of specialty pharmacy and the growth of programs that have been supported by 340B. But again, it has become a significant number. Consider, if you will, looking at the specialty price change impact, or specialty drug price change impact. Again, recent analysis that was put together in Health Affairs and was also outlined in JAMA, not Health Affairs, as well as an analysis done by Dr. Fine, looked at price increases and the gross net bubble over the course of the last 7 years. So I took the liberty of looking at what changed from a patient and a payer and from a 340B hospital perspective for a hypothetical average specialty drug that was introduced at a price of $1,000 in the year 2013. So my hypothetical $1,000 drug in 2013 was offered in the rebated market, to my second line below there, at roughly a $125 discount. So in order to gain formulary access and in order to get on health plan, to be made available to health plans, that manufacturer of this hypothetical drug gave a $125 concession to the PBM and to the health plan on the day that the drug was released. And on the day that the drug was released, they gave a 23.1% discount to all 340B hospitals. And so the drug was made available to you all at $769. The co-payment or the co-insurance for that drug for patients, the bottom line here, which is based upon that $1,000, is roughly 26%, or $260. Over the course of the next 6 years, list price grew, as did the discounts that were associated with it. And as many have pointed out, a significant chunk of that discount, or a significant chunk of that price increase, went back both as discounts to 340B hospitals and as rebates to PBMs and to health plans. And so if we look out to 2019, on average, over the course of the 7 years, that drug increased in price from $1,000 at its launch to $1,727 list price. And as was pointed out frequently, that's a price that virtually no one paid. However, if you look down at the bottom line again, you'll see that patients are now paying a copay against that list price of $449. So our patient, over the course of the 7-year period, watched their copay for this prescription rise by almost $200 nearly 1.7 times what happened over the course of that because of the list price increases. However, the health plan saw a modest increase from 875 to 959, while during that period, the hospitals themselves, 340B hospitals, saw virtually no price increase at all because price increases that were taken by the supplier were well above the CPIU. So a message here again is that in the year 2013, 340B spread for a hospital was $231. That's the take-home or the 340B savings. On that same prescription filled 7 years later, that hospital made 4.2 times the amount that they made in 2013, or $965. The benefits to 340B are tied and deeply intertwined with the way in which the market works as a whole. Another point that I want to make, and I think it's one that we've talked about on a number of occasions, and again, I'll hark back both to some time that we've taken in the 340B handbook, but also to a LinkedIn article that I posted about the time that Vizient and ASHP came out with their price and inflation reviews, is that price increases are experienced differently by 340B hospitals. While you certainly encounter the same price challenges for the new and expensive drug that anybody else does, price increases for 340B hospitals should be considered separately because, as I pointed out in the earlier slide, there's relatively limited impact for actual price increases above the CPIU for hospitals. 340B hospital drug budgets and benchmarking should be done separately. Chat briefly here. As the size and scope of the 340B program have grown, in addition to almost half of the hospitals in the country being in, or slightly more than half of the hospitals in the country being in 340B, the typical hospital makes more than half of its purchases at 340B price. That obviously varies pretty widely, but across the book of hospitals that we look at, 340B sales or 340B purchases are actually slightly over half of what hospitals buy. The amount of activity in specialty drugs and the amount of activity in ambulatory care drive growth in that sector, while inpatient sales or inpatient purchases remain relatively modest or only impacted by the addition of new drugs. In addition, and I think this is an often undersold element for those of you who are responsible in the supply chain, hospitals that are subject to the GPO prohibition are also a little bit hamstrung by what they can do with responding to shortages or other challenges, because the GPO prohibition limits their ability to purchase at WAC, number one, or limits their ability only to purchasing at WAC, a significantly higher price, or have limited access to private label drugs, those drugs that are made by the GPOs in an effort to try to improve the drug supply chain, are differentially available to hospitals that are subject to the GPO prohibition. 340B savings has been in the public dialogue, and we'll go through this quickly. In preparing for this, I actually looked at everything that came across my desk or that I could round up that was in the healthcare press in the month of December as I was preparing for this. Hardly a day goes by. I've got 10 of them posted here, but there are a number of articles looking at how savings were accrued, how savings were spent, how reimbursement plays. Some of these look at things like the OPPS changes. Others look at how savings are delivered to patients. Some of them look at how savings are actually accrued and support the hospitals. But 340B startlingly remains front and center in the public dialogue. This most recent conversation, I think, speaks also to the importance of savings here. This is a gentleman, Mike Mullins, who's the CEO of the Mountain Health Network in West Virginia, made a statement in his local paper that if the federal 340B program was ever eliminated, every hospital, every not-for-profit hospital in West Virginia would have an operating loss, and that's certainly not far-fetched for any of us to imagine. And while the 340B program is unlikely to be eliminated, there are a variety of efforts to make sure that hospitals are sustained and the 340B program is sustained. One of the points that we'd like to bring home to you is that market forces certainly operate in 340B in a way that mean that there are other threats beyond the elimination or significant legislative changes to the program. 340B savings reporting, I mean, there's a lot of discussion about transparency, and I already alluded to 340B Health Survey and drug channels looked and finding that $15 billion worth of discounts are provided to hospitals that participate in the 340B program. Individual hospitals have started to report their savings, and there's a fairly wide variation. The hospitals that I've listed here in the report pieces that I've held up are ones that have actually been published on the web. So if you go look, Geisinger and Stanford on the high end, large-scale academic medical centers that have significant offsets to their drug budgets as it relates to their use of availability of the 340B program, all the way down to a relatively modest hospital on the bottom here that's relatively close to average. But increasingly, hospitals believe that it is important not only to provide this information for discussion in the public dialogue, like we're having now, but also to understand how it impacts their ability to deliver care. Back to our friend Mr. Mullins earlier, Geisinger, Stanford, Regional One, Genesis, and Avista Aventis would have to materially alter their delivery of care to uninsured, underinsured, and even to other patients in their communities with 340B to change materially. I want to make certain that one of the things that we want to communicate to you today is that it's not only is it important to be willing to communicate clearly and effectively to the public, it's important to be able to communicate savings clearly and effectively inside of your organization to make sure that the impact of 340B is well and appropriately understood. There are a variety of calculation templates out there. 340B Health provides you with one that looks at communicating impact more broadly. Apexis provides templates in a number of places on its website and its tool set. And AHA has also put together one recently that looks at public policy opportunities as well. I'll not spend a lot of time on this particular slide, but 340B savings really falls into, I think, two things. We've got a column, two sets. We've got a column here. The first on the left-hand side are threats which are related to public policy or perhaps legislative changes. On the right side are business and other non-legislative impacts, including payer and PBM network limitations. I'm sure all of you are familiar with payers looking to pay 340B specific rates for prescriptions in the specialty space. Reimbursement schemes that look to make sure that duplicate commercial discount is addressed are starting to come together. So 340B savings threats, or the threats to those hospitals that we talked about in the previous slides, come not only from the opportunity for legislative or regulatory changes to take place, but also from things that are as simple as payers wanting to pay differently because of your 340B status. I'll transition over to Kevin now. We'll talk about the origin 340B savings and how to go about managing and understanding it.
Perfect. Thanks, Andy. You just provided us with a great 340B market overview. I'm going to spend a few minutes here talking to you about 340B at the actual health system level. So you hear the term 340B savings. At its most basic level, what we're talking about is cases where the net acquisition cost of a drug is lower than what the covered entity would have paid if it were in fact not in the 340B program. And the most typically used proxy for that is GPO pricing. So when we're out in the field, where we see 340B savings, majority of it is in the four areas here that are detailed on this slide. The first box there on the left is what is frequently referred to as the mixed use area. So the classic example of that is a hospital emergency room. So the drugs in the ED are replenished by the central pharmacy. Some of the patients come into the ED, are seen for 15 or 20 minutes. Some drug products may be administered. They're clearly outpatient. They're discharged as outpatients, very clear cut. There are other patients that come in, maybe higher acuity, receive drug therapy, remain in observation, and if their acuity doesn't resolve, ultimately they can become inpatients. So it's a single area supplied by the same location in the hospital. Some of the patients meet the outpatient criteria, some of them meet the inpatient criteria. And this is, again, is where the covered entity would be using software to determine which drugs and which patients fall into those categories. The second area is the ambulatory care, ambulatory clinic, or infusion center space. One of the things that we've seen a tremendous shift in the last 10 years is the migration from infusion therapies that used to be provided in the hospital are now done on an outpatient basis. So oncology treatments for rheumatoid arthritis, plaque psoriasis, Crohn's disease, et cetera. So, and this is the space where there are a great many specialty drugs have come to market. So that is an area of big savings. That space actually can be mixed use, or it can be what some people refer to as a clean site, a pure site, where every single patient qualifies for 340B. It depends on how the particular covered entity is set up from a cost report perspective. The third box there is retail pharmacy. Not every covered entity has retail pharmacy, but many do. It's probably, that could be broken into two buckets in and of itself. There's a traditional pharmacy, which is the $75 to $85 median price regular prescription pharmacy, and then specialty drugs. They're all technically dispensed under a retail pharmacy license, but specialty drugs are probably more in the $2,000 to $3,000 range per prescription, and typically have some additional requirements in terms of clinical oversight and shipping and storage and clinical follow-up and communication and that sort of thing. The fourth box is contract pharmacy, and these relationships are pretty much unique to the covered entity space. The 340B statute allows for the contractual relationship of retail pharmacies back to the covered entity. And what that means is that prescriptions for qualified patients where there is a contract, the contract pharmacy can basically shift the revenue proceeds of that prescription over to the covered entity in exchange for a fee and then replenishment of the drug that was dispensed, that being purchased at the 340B price. And just like the retail pharmacy discussion, that kind of falls into two general categories. There's the $75 to $80 more traditional blood pressure medication, that sort of prescription, and then the specialty drugs, the specialty infusion and oral drugs that are much higher in cost and require a greater degree of clinical care and oversight. So what we find when we get at the field level is that there are a number of variables that drive 340B savings. And it's actually pretty amazing. You can have two 500-bed hospitals that are across the street from each other, and both of them in the 340B program. But because of some of these variables that you see listed here, there can be an order of magnitude difference in their 340B savings because these things have such a great impact. Being in the pharmacy space for quite a while, one of the things that always amazes me is a typical hospital pharmacy now has products where a single dose costs 0.001 cent per dose, and they're also dispensing items that are $25 or $35 or $45,000 per dose. So I bring that up because it makes kind of a standard rule of thumb hard to apply. You really do need to understand the product mix, which specific NDCs that a given site is using, because they can have such a dramatic impact on both drug spend and savings. The payer mix that we have listed there is primarily focused on Medicaid, and Andy mentioned this earlier. Each covered entity has the option to elect to either carve in or carve out. The most important factor being here that by statute, the discount associated with Medicaid cannot be duplicated. So in a great many cases, either the covered entity is billing Medicaid and they're using the 340B price, and they are ultimately billing it at cost, passing that full savings over to the Medicaid entity. This is all state by state, but that's the typical scenario where the items are billed at cost. Or if they elect to carve out, they can charge at a higher amount. Unfortunately, if they're a DISH entity, they actually have to use WAC purchased drug to do that, and then ultimately the state can obtain the discount through a rebate process. The other thing that Andy mentioned, and I'll expand upon, is there is a material difference in the type of savings that one typically sees, largely based on the covered entity type. So the 500 hospital example that I used, you very well could have a 500-bed hospital that's DISH and across the street a 500-bed hospital that is a rural referral center. That actually can happen. And the number of drugs that would qualify for the discount could differ substantially between the two. I'm going to talk about WAC premium here in a little bit more detail in a minute, but I can't emphasize enough how important, again, the details are. And people get a little bit tired, I think, sometimes when they work with our group, because we talk about the mix. It is kind of like real estate with location. So with its product mix, its payer mix, and then also provider mix. So where your referring physicians live on the Medicare cost report has a heavy impact on whether or not the prescriptions and the drug orders that they write will qualify for the 340B drug discount or not. So those are the elements that we're certainly trying to track and look at when we're looking at this from an operational perspective. So what I'm showing you here is kind of this would be a very typical setup that we would see for a large DISH hospital, where they would have a mixed use area. It's serving their emergency room. It's serving all of their inpatient area. It's also servicing their infusion suite. They have a retail pharmacy. They also have a multitude of contract pharmacy relationships. They're using a software product here that's determining the eligibility of patients across those three buckets. And as you can see, there's a slight difference here in terms of how the benefit is ultimately realized by the hospital on the cases where it's an inpatient use. There's not a revenue necessarily associated with it. Those items are going to fall to the cost report. But the infusion center, the retail pharmacy, and the contract pharmacy all have revenue, and then there is, again, offsetting cost of goods, whatever the drugs cost, whatever the operational cost is associated with the actual provision of care and the dispensing of that prescription, and then ultimately what the organization is left with is the net of that. And again, in a typical DISH hospital, the key drivers that we would see here in terms of what that net number is going to be highly impacted by the products that they're dispensing. And again, the more specialty drugs, typically the higher the drug spend will be, and typically the higher that the savings will be. 340B eligibility, again, obviously a key factor on what percentage in the retail space, and the contract pharmacy, 100% of the contract pharmacy patients must qualify. That is the definition of a contract pharmacy patient, is that they qualify. And then again, the payer mix, what percentage is Medicaid, where ultimately the savings is passed back to the state Medicaid program. So given all that complexity, I'm going to talk a little bit about some tools and strategies, and tell you a little bit about some of the work that we've done in the field, and also some great work that we've seen some of our hospital partners who developed some of these tools on their own and are using them to be best in class. One of the things that we do see is sometimes there is a temptation just to do the math and subtract the WAC and the 340B pricing from GPO and just take that gross savings number. It is a lot more granular than that, and I think given the size and the scale, as Andy has described, and how important it is now within most of these organizations, this complexity, its financial role, and then you lay the compliance piece over the top of this, it is well worth the while of every covered entity to have detailed management reporting capabilities as it relates to the 340B program. So again, here, there's a list. I'm not going to walk you through all of these, but these are certainly elements that need to be taken into account as we're trying to understand what the true net savings in. The last item here is WAC premium, which is particularly important. So at DISH sites, which constitute the largest share of 340B sales and savings, the GPO prohibition does apply. So they cannot use a GPO item for an outpatient dispense, which means those items ultimately have to be purchased on the WAC account. So we look at the WAC account and say WAC purchases in and of themselves are neither good nor bad. They're just on the WAC account. The ones you're concerned about are those that have a premium, meaning where the WAC price is higher than the GPO price. You're paying a premium over what you would have paid had you been outside the program in an effort to be compliant, since you cannot use the GPO price in that dispense. So one of the things that reporting and tools should have is a way to measure and track that WAC premium and provide the 340B working team with a way to track that. We clearly see that people have reporting and analytics tools that allow them to see that WAC premium, certainly manage that much, much more efficiently than those that do not. The 340B program discounts are all important, but certainly there are other standard trade discounts that the pharmacy should certainly pursue and manage beyond that. There are also, Andy talked a little bit about orphan drugs. So orphan drugs is a case where for sole community hospitals, rural referral centers, and critical access hospitals that utilize orphan drugs, they're technically outside the reach of the program. But what we find is a very substantial number of manufacturers do offer voluntary pricing in this space. So one of the things we spend a great deal of time is working with these covered entities and facilitating their optimizing this voluntary pricing that's provided by the manufacturer. There are some other items that are outside the program by definition, vaccines probably being one that people commonly refer to. And the prime vendor is of a great help in that area. So the prime vendor typically has contracting that they do that's outside of 340B that allows these entities to obtain these through the prime vendor contracts. So our group is really, our primary role is to provide consultative support at the field level, and certainly what we have seen in the field, we have a number of customers that have developed pretty robust 340B reporting. We also have a substantial population, though, that have really kind of struggled in this space. So about 2 years ago, in an effort to support these customers, we built an analytics engine where we could go in and these are not thousands of transactions. At each one of these sites, it's literally millions to tens of millions of transactions that have to be analyzed to be able to get to the core of where the opportunities are or where a potential compliance breach may lie. We've gotten ourselves to the point now that we have about 75 to 100 McKesson customers that we're working with where we have provided them with some analytic oversight. Our 2.0 version of this is we're going to be rolling out in the not too distant future inside of our Macro Helix 340B software product. So we're actually going to have a real-time customer-facing dashboard that will be available to those customers as part of the Macro Helix reporting suite. So what I do want to share with you is just a couple of views from the tool that we use, and to give you some idea of the level of detail that can be acquired, and how we use this and communicate this up inside of a 340B organization. This is one of the screenshots from our dashboard that basically details a running 12 months worth of spend at an organization. So it breaks it down by the 3 account types, GPO, PHS, and WAC, and shows that trending over 12 months. We can look at a prior year and do comparisons. This does a recalculation on the fly. This is not the live version that I'm showing here, but if I click one of these areas, I say show me just the outpatient pharmacy, the entire dashboard recalculates and shows just the outpatient pharmacy or just the hospital. Or if I come up here and say show me just the PHS spend, and I click that, it will basically show me just the PHS spend. The view that we use for savings is somewhat similar, 12 running months. These bars here representing the discount that ultimately is obtained by the 340B price being lower. And then down at the bottom here, we're also showing the WAC premium. So this is the savings. This is the take back down here. I've rescaled the WAC premium here on the scale up here so that we can more easily see the patterns. The good news is that the WAC premium is much, much lower than what the savings are, but nonetheless, this is what the customer wants to be able to work and pay attention to. So we bring that up here and show that in a broader scale to allow us to take a look at that from a trending perspective. And then we have kind of what we call the service line view. So we can have a discussion with the chief financial officer and help them kind of understand where the savings are coming from, what drugs, and on the fly I can change this to therapeutic class or down to the individual vial level, but we can get a pretty good sense in the different areas which drug products and which therapeutic classes are driving the savings for the organization. And also it kind of helps to understand that, as Andy said, the discounts range from 15% to 99.9%. So you can see here that the savings and the drug spend, they're not consistent with each other, and that's because the discounts are different by drug agent. So I think having that insight is certainly very helpful from a day-to-day management perspective. So in conclusion, I think what we'd like to share is that we certainly see that the size and the scale and the trending that Andy was talking about for the 340B program means that every covered entity should have their full attention. The pharmacy level reporting, I think, is a great starting point, and everybody should have that at the minimum. There's certainly other opportunities as it relates to revenue and billing and collections and contract pharmacy management and other things, but the core understanding the core savings and savings opportunities associated with the pharmacy department have demonstrated, at least from our field experience, to be highly valuable in facilitating operations, strategy, and compliance oversight. And quite frankly, to be best in class in 340B, it's our opinion that you really have to have these things. So with that, I know we're coming up on the hour. Andy, I'll turn it back to you for any final comments, or I'll let you manage the questions.
Very good. Well, thank you, Kevin, and appreciate those of you that have spent your afternoon with us, or spent an hour this afternoon with us. I will call to your attention, we do have the opportunity. There's a Q&A. If you'll click on Q&A, you have an opportunity to ask questions. We have several, and we'll spend some time going through them briefly in the time that we have remaining, and we'll be able to link back to make sure that if you have a specific question that is answered. I'll take the first one here. One that this is relative to orphan drugs. The orphan drug exclusion, this is from one of the smaller rural hospitals or rural referral centers, Soul Community Hospital, says, I have a letter from the manufacturer stating that we can purchase the medication at 340B price, and I've only used it in the mixed use area. What are your thoughts about being able to use this for contract pharmacy? And so we found that quite a number of manufacturers, as Kevin mentioned, were open to allowing rural referral centers, Soul Community Hospitals, cancer centers, and the critical access hospitals access to the discounts, even though they're not required by the 340B statute. They're not covered outpatient drugs. However, this is one of those interesting intersections where having a little bit of more information makes a difference, that does not routinely extend to contract pharmacies. And so one of the things that we found over time is that most orphan drugs, or certainly many orphan drugs, are also specialty drugs. And so the intersection of the specialty drug rules and the orphan drug rules means that you need to have an answer to both questions. So it's not routine that an orphan drug that's offered to you at a discounted price is available also to be used in contract pharmacy. So in answer to the specific question, you should ask if you are offered an orphan drug price, if it can be extended to your contract pharmacies, and get that as a part, get that in writing so that you can set that up, number one. And number two, you should expect that that answer oftentimes may be no, or certainly is going to be colored by how the manufacturer is offering that product in the overall specialty drug marketplace. So I don't know, Kevin, did you are you looking at the question list here?
Yeah, so one of the questions that I see here is a question about the, we talked about how this all impacts the covered entities, but what about the wholesale distributor, which I think is actually a great question. So the wholesaler plays a very large role in this, given that so much of 340B is in fact transactional. We work very closely with the prime vendor, as well as we have a contractual relationship with every single manufacturer where we distribute their drugs. So we certainly get guidance in working with the prime vendor in terms of how we set up accounts. So one of the compliance measures that we take is we're glad to set new accounts up, but one of the requirements is we have to be able to see that organization has been approved and has been listed on the OPA website. That for us is the source of truth. And certainly we go through and also do compliance audits on those accounts. Andy also mentioned that on orphan drugs, we're constantly in communication with manufacturers to determine how they view the orphan drug status, and verifying that we have the pricing that they want loaded into those into the proper accounts. So even though we are not covered entities, we are very focused on the compliance side of things, and certainly work very closely again with the prime vendor to make sure that we're facilitating that and making this all a manageable process for our covered entity customers.
Great, thank you, Kevin. Got about 2 minutes, and I'll quick closing comments. I see a couple related to how 340B pricing and rebates and other things are converging. I will come back again with the one question says, are rebates and commercial drug pricing differentials with 340B increasing or decreasing? And I think we made the point earlier here, which I think is a theme here. Rebated prices and 340B prices, particularly as it relates to Medicaid, are very, very much the same. And so over time, much of what's going on in the marketplace recently has reflected not just what's going on in 340B, but what's gone on in the commercial marketplace as a result of price increases and other changes. Remember, 340B is tied to AMP, or the average market price. So one, they're converging, and two, I think, again, the threats here to 340B are certainly something to keep in mind as you watch what's going on with rebates and other discussions related to drug pricing. 340B will be impacted by that as well. Finally, in closing, in the last minute, I do want to let you know that this is going to be recorded and will be available for you to replay along with the slide deck. We had several questions asking whether or not you can replay it for other members of your organization or for your 340B or health system leadership, and you're certainly welcome to do so. We appreciate your time today, and thank you, Beckers, for supporting this. Have a good rest of the day.
Yeah, thank you. Thank you so much, Andrew and Kevin, for really that fantastic presentation and all of your thoughtful answers to everyone's questions today. Yeah, that is all the time that we have for today. But I want to once again also thank McKesson for sponsoring today's webinar. And please enjoy the rest of your day, and we look forward to having you join us for future webinars.